I am now going to present the case of a gentleman called Stanley. Stanley is an 82-year-old gentleman with a long history of type 2 diabetes, and he has developed many of the complications of this, including ischemic heart disease and chronic kidney disease. He's had a significant stroke in the past, and as a result has a dense right-sided weakness and is aphasic, with the only word he's really able to say being yes. The stroke has left him very dependent, and he's in a nursing home and needs a hoist to be transferred. He was admitted to the acute hospital with a chest infection. Now, the report from the night team had been that Stanley had been very aggressive overnight. When questioned as to what exactly that meant, it turned out he'd been shouting out and hitting out when the staff were attending to him. He seemed especially distressed by personal care. He was unable to tolerate having bloods or venflons put in place, and as a result had missed doses of his antibiotics. Overnight he'd been seen by the junior doctor, who had prescribed and given him some intramuscular haloperidol. On approaching Stanley, from the end of the bed he looked relaxed, and he gave a friendly yes in response to questions. However, on approaching him from the right, all this changed. He became distressed, the tone of his yes became shouting and forceful. Yes, yes! He looked very pained and frightened. He visibly flinched away when you went to touch him, pushing people away and hitting out. Even from the end of the bed, you could see his respiratory rate increase dramatically. He seemed very distressed by even light touch on the right-hand side. However, when approached from the left, he was much more settled. Here you can see how he was scored using the Abbey pain scale. The change in the tone of his voice was felt to be severe and gave him a score of 3. The pained grimacing that he had gave him a score of 2 for facial expression. The guarding, the flinching, gave him a score of 3 for the change in body language. Pushing people away and hitting out scored him a 3 for behavioural change. And the marked increase in respiratory rate gave him a 2 for physiological change. Although he did not have an injury as such, the dense right-sided hemiparesis was felt to represent a 2 in physical changes. Totaled up, this gave him a pain score total of 15, which is indicative of severe pain. We wondered whether he might have post-stroke pain, and he was given low-dose Oromorph regularly with an excellent effect. Rescoring him in the Abbey, it had fallen from 15 to 6. At this point, he was able to comply well with care with no distress, except the antibiotics he needed for his chest infection. With the opiates, we didn't forget to give him some laxatives, and as we felt that this might be a neuropathic pain, gabapentin 100 mg 3 times a day was added in. On speaking to Stanley's next of kin, who was his brother, he agreed that he thought he had been very sore and that this had probably been a problem since a stroke 3 years ago. Stanley recovered well from his chest infection and was able to be discharged back home. Now that he was established in the gabapentin, we had suggested to the GP they may be able to wean down the morphine depending on how he managed. So Stanley's case has taught us that challenging behaviour in people with cognitive impairment may be distress from pain. And I would say that pain actually needs to be actively excluded in every case of distressed behaviour in somebody who has a cognitive impairment. Using your problem-solving skills and paying attention to and observing what causes behaviours may give clues, as may the history and clinical examination. Here the Abbey was very useful in helping us to structure our assessment and also to monitor the response to the therapeutic trial of analgesia. Characterisation of the type or the cause of the pain can help guide analgesia, and here gabapentin was tried because of the suggestion of neuropathic pain. It's important that we recognise that people in hospital may have chronic pain as well as acute pain related to their admission. And finally, family may have very useful information for us but may not volunteer this unless we actually ask them. I'm now going to pass you over to Joanne McShane, who has another case study for us.
Thanks, Hazel. I'm now going to introduce to you Grace's case study. My name is Joanne McSheen and I'm a clinical nurse specialist in acute pain management. Grace is a 70-year-old lady with a history of Alzheimer's disease, osteoporosis and ischemic heart disease. She was referred by her GP 1 week ago with acute back pain and no injury apparent. An X-ray showed that Grace had osteoporotic wedge fractures of the thoracic vertebrae at level T10, T11. Pain was not well controlled and our daughter concerned about this, and a referral was made to the acute pain service. Grace was prescribed PRN cocodamol 8500, which was ineffective, and then she was prescribed cocodamol 3500, which caused drowsiness, so it was changed back to cocodamol 8500 again. Junior doctor was reluctant to prescribe further analgesia until a pain service review had been undertaken, as he was concerned that Grace may become drowsy or increasingly confused with stronger analgesia due to her cognitive impairment. When dealing with cognitively impaired patients, people often worry that opioid analgesics will worsen confusion. However, we should be mindful that it is vital to treat pain, as undertreated pain can cause delirium. Analgesic regimens should be assessed for efficacy and side effects. On assessing Grace, she was unable to accurately score her pain using the usual scales due to her cognitive impairment. She was vocalising her pain, shouting out that it was sore, sore, sore. She was lying in her bed, distressed and agitated. She was noted to be tachycardic and hypertensive. She was vocalising pain, grimacing on gentle touch to the left side of her back. She was guarding the left side of her back and curled up on her right side. She was pushing the nurse's hands away when attempting to examine her, and she was refusing to sit in her chair immobilised and mostly lying in her bed. Her daughter described other pain-related behaviours such as reluctance to eat and drink. She was becoming withdrawn, sleep disturbances and shouting out during the night, and taking to her bed more frequently. Families are often very aware of their relatives' pain and they're a reliable source of information. Thanks. The ward nurse completed the Abbey pain scale in conjunction with Grace's daughter in acute pain CNS. Each question of the Abbey pain scale was scored as follows. Question 1, vocalisation. Grace was shouting out that she was sore, sore, sore. She scored 3 in this section. Question 2, facial expression. Grace was grimacing and gentle touch to the left side of her back and sometimes grimacing out with this. She scored 3 in this section. Question 3, change in body language. Grace had become more withdrawn and she was guarding her left side constantly. She scored 2 in this section. Question 4, behavioural changes. Grace was reluctant to eat and drink and refusing to sit in her chair immobilised. She had taken to her bed over the past week. She scored 3 in this section. Question 5, physiological changes. Grace's heart rate and blood pressure had increased due to pain and distress. She scored 1 in this section. Question 6, physical changes. Grace had osteoporotic wedge fractures of her thoracic vertebrae, which can be very painful. She scored 2 in this section. Grace scored 13 in total. This indicated that Grace had moderate pain. The type of pain she was experiencing was acute pain. In accordance with the World Health Organisation analgesic ladder, Grace was prescribed a weak opioid analgesic. Cocodamol 8500 proved ineffective, but cocodamol 3500 caused drowsiness. Grace was therefore prescribed a one-off dose of dihydrocodone, 30 mg, and an evaluation of efficacy and side effects completed at 1 hour. Her pain may have been better controlled if the 8500 cocodamol had been prescribed regularly. Evaluation after an hour should always be completed to determine the effectiveness of any pain relieving measures or if further action is required. Non-steroidal anti-inflammatory drugs are usually contraindicated in frail elderly patients. When reviewing Grace, she appeared more settled, less distressed and less agitated. She no longer was grimacing and she was guarding her back less often. When asked about her pain, she said it was sore but better sore. She had some discomfort but no distress when she was asked to move. She had no side effects from the dihydrocodone. Her daughter felt her pain was improved and was happy that Grace was more settled and less distressed. Abbey pain scale was now 4, in keeping with mild pain. Dihydrocodone and paracetamol were prescribed 4 times daily. This ensured that Grace received regular analgesia. Oral morphine was also prescribed for breakthrough pain. Abbey's pain scale was to be completed 4 hourly and treat pain if needed. Regular laxatives were also prescribed. As we've already heard, cognitively impaired patients are less likely to ask for breakthrough analgesia. Where possible, regular analgesia should be prescribed to ensure they are not overlooked if they do not have the ability to report pain or request PRN analgesia. They're also more likely to have their pain undertreated than their cognitively intact counterparts of the same age. This is probably due to underreporting and difficulties in pain assessment. An oral morphine breakthrough is especially useful before shivering, physio, etc. Functionally recovered and discharged with a plan to wean analgesia as able. Her daughter was delighted with this and aware that fractures may take months to heal. Stacey's pain could have been better managed if staff had better knowledge of assessing pain in patients with cognitive impairment. Regular analgesia had been prescribed, especially knowing that Grace was unable to ask for PRN analgesia, and the Abbey pain scale had been used as it was known that Grace had Alzheimer's disease and was cognitively impaired. The World Health Organisation analgesia ladder is easy to access. It's available online. It's also available in the Drugs and Therapeutic Handbook, and you may have a modified version in your own area. You can use it to guide pain management. Pain scores, efficacy of analgesia and side effects should be assessed whenever after any intervention. The Abbey pain scale should be used as part of an overall pain management plan.
Thank you very much, Joanne. So to pull it all together, assessing pain and cognitive impairment is difficult. There's lots of barriers to doing it well, which can lead to the person with the cognitive impairment, especially in the hospital setting, having their pain undertreated and therefore suffering. It's really important that if a person with a cognitive impairment has distress, we consider pain. And as I mentioned, it should really be ruled out as a cause of distress. Assessment of pain in this patient group is a skill which we will develop as we gain experience and training, but having a tool such as the Abbey Pain Tool available can be a very good way to structure your assessment. Using it can help us to further develop our skills and also to standardise how we record things and allow repeated assessments to be compared. Finally, a reminder that we should always assess the effectiveness of any intervention we do for pain. Has it helped? If not, why not? What's the next step? So now it just remains to me to thank you all very much for listening. I hope you found it a helpful presentation.